Hi, everyone. I'm Noah Ivers. I'm a family doc at Women's College Hospital, and I run a research program in implementation science and hold a Canada Research Chair in that space, and think an inordinate amount about how we can, measure quality of care and how we can give those data back to healthcare professionals, teams, and organizations. And super happy that Sabrina's here to talk to us about sort of some of her plans in that space. I'm going to read her bio, but the thing that's important to know really is that she's one of Canada's leading primary care researchers and is exceptionally nice. But I'll read the bio. So Dr. Wong's research focuses on the delivery and organization of primary healthcare services. She examines both supply side factors, such as human resources, that influence the quality of primary healthcare, and demand side factors, such as access to care and the association of sector, like primary care or public health collaborations on integration of care. Sabrina has expertise working with large admin data, as well as other methods, including EMR data, which I gather she's going to be talking to us about today. She is, as was mentioned, the co-lead of both the Pan-Canadian Primary Care Sentinel Surveillance Network, which is highly relevant, and you can see a part of the title slide, but also the national sort of SPORE integrated sort of primary care network. And she leads these network nodes in BC and sort of across Canada with her co-leads. And in all her work, she emphasizes sort of collaboration with relevant stakeholders and end users, whether that be clinicians, patients, researchers, agencies, NGOs, health authorities, etc. Yeah, how's that, Sabrina?
Sounds great. Sounds great.
Okay, you're in charge.
Okay. Let's see here. I'm trying to look at this. It's really weird. Okay. Okay, so I'm going to start into this presentation, and hopefully you all will have questions, and we're going to have a lot of time for discussion. And hopefully you'll all jump into this discussion, because it looks like a fairly small group today compared to what I've seen before. But I don't know, I can't really see anything while sharing the screen. So, okay, well, thank you for inviting me to be part of the KT Canada series. And it's really an honor and privilege to be here and to talk about a subject that I'm really passionate about, and that is the Canadian Primary Care Sentinel Surveillance Network. And today we're going to talk about the use of primary care electronic medical record data to inform practice quality improvement. So these are some of the learning objectives, to talk about what is this kind of data, to learn about how we can use this data in quality improvement in practice, and then to identify tips for improving the science of quality improvement in primary care. So I'm going to give you an overview of what Simpson is for those of you who don't know about it. What happens to the data once it leaves the electronic medical record. I'm going to present a couple of case studies and then provide some tips of using the Simpson data for quality improvement purposes. So why is this really important, and why do we spend so much time doing this in primary care? It's a slide we all love to show, and it's basically that there is a lot more people that are going to see their general practitioner, family physician, CHC, nurse practitioner, in the community-based care, community-based primary care, compared to specialists or getting x-rays or labs. And most of the system is really focused on, and data are coming from the hospital system. And this is the only system probably in Canada where you're going to get a lot of electronic medical record data from primary care practices. So what is Simpson? It's a network of 13 practice-based research and learning networks across Canada. It's currently available and in use in 8 provinces and 1 territory in Canada, and we're actively working on a network node, excitingly, in Saskatchewan. We're also working on a second additional network node in Quebec, as well as talking to other provinces and territories in terms of contributing data in this way to Simpson. So they're located all across the country. They're run by different colleagues and researchers in primary care, most of whom are family physicians, but there's some other folks also involved, like a pharmacist in Quebec and epidemiologists. And you can see here the collection of different universities and different places where people are located to help to run Simpson. So I'm really speaking on behalf of all of these people. I can't run this myself. It's really a team effort, and there's a lot of people across the country that care deeply about Simpson and the kinds of data and relationships that we have with primary care. So what does it do? It creates a high quality, cleaned and coded, de-identified primary care database. It started in 2008, so there's 14 years of R&D, research and development, behind this database. It is physician built and physician led. It was originally a brainchild of a physician at Queen's. Oh man, how did I forget his name? Rick Birtwistle, Dr. Rick Birtwistle. It was his brainchild. He started this back in 2008. It is done in collaboration with the College of Family Physicians of Canada, and originally was funded by the Public Health Agency of Canada. So that's sort of what it looks like. Okay. Yeah, go ahead. Someone has a question? Or no? Lisa, did you have a question, or no? You just unmuted yourself by mistake.
I think that was like the Zoom equivalent of a pocket dial. So
oh shoot, I was really hoping for a question. Dang.
But feel free, folks. Clearly, Sabrina's happy to be interrupted. Just put up a hand, a Zoom hand, or type something in the chat. No problem.
Yeah. Oh, Gail. Yes, Gail. Gail is one of our people in Manitoba, working very closely with Dr. Alex Singer. Mm-hmm. Yes, Dr. Hallis.
I have a question that just occurred to me, despite the fact that I'm so aware of Simpson data. But in the course of collecting, or not collecting, but accumulating all of these interested providers who are contributing their point of care data to Simpson, do we have a sense of who they are? Like, do we have data around the providers in addition to the patients? Is that coming across clearly?
Yeah, no, we definitely have some data on that. So I'm going to talk about the electronic medical record data today, but the part that I actually forget to talk about is the fact that we run an organizational survey alongside the electronic medical record extraction. And so we do have some data around the provider characteristics, and also the types of models of care that people are working in. So that's absolutely there. And yeah, you want to help us analyze it and get it out to clinicians, that would be awesome, because there's a lot to do. Okay, so the Simpson data, the electronic medical record data, is from all networks. As of 2020, there was about 1.7 million patients submitting their data, which is and then almost 1,400 providers from about 254 places of primary care across Canada. And you can see different electronic medical record systems that we use. So we can extract data from, TELUS, Accuro, Oscar, InterHealth, Mile, there's a bunch of them across the country. So we work with multiple vendors across the country. What are the types of data that are included? I have a list there. And essentially what we do is we extract data from different structured fields in the electronic medical record. And then we put them into tables. And the tables include, physical measurements, prescription, medications, lab results, et cetera, et cetera. So the data are put into tables, and then you can also link the data across time so that you can see patients having multiple visits, for instance, and the types of things that happened over their visits, that kind of thing. So once the data come in, then there's a bunch of stuff that we do in terms of cleaning and coding. And so the data are input into the electronic medical record, and then they're extracted from the system and pulled together into a standardized, what we call a Simpson data schema. And that means that we take the raw data that is in the EMRs and we standardize it. And we do that through things such as text classification. So we use standardized ontologies and terminologies. We also do things like pattern matching and machine learning algorithms. And so you can see the different kinds of things that we do in terms of the data cleaning. And then you can see also that we will de-identify the data as if there are anything that comes in. So an important thing to know about Simpson is it never takes or extracts personal health identifiable information from the chart with the electronic medical record data. So we take, like I said, extract data from different fields and are very careful not to take these direct identifiers, so names, PHNs, and phone numbers, etc. So that's de-identification. The other thing that we do is we also anonymize the data once it comes in to remove any names or phone numbers, etc. that we see. Now, there is a different part of what we do in terms of linking data, because it can be linked to administrative data. And when we do that, we will do a separate file extraction that only contains the Simpson ID with the personal health identifier information. And then that file would go to, for instance, Manitoba Health Policy Center or Population Data BC or ICES, and they would then do the linkage with this specific linkage file. Okay, so here's an example of what we do in terms of data cleaning. You'd never think the data are so messy when they come out, because when you look at the EMR, it makes sense. But then when you're extracting the data on the back end, there's some things that you have to do in order to clean up the text and also clean up the data fields. So you can see there's an example there. Just take the middle row, Percocet, and it's, this is how it's written in the EMR, and then we will go through and clean the text so that it comes out as oxycodone and paracetamol. And then we also have other fields so that we assign an ATC code to it. And then we also have other fields that will tell you about the dose and also the duration. So that's all stuff that sort of happens on the back end and all of our transformations. And this is the transformation of the data is really integral to the use of the data for research and surveillance. And I will say that all of this data cleaning, what we call data cleaning, but really informatics, is done by our data managers. There's multiple different data managers across the country that will extract the data and then clean it and code it to a certain standard. And this is an example that is showing you what happens when we first extract the data and then when we clean it up and assign it an ATC code. This next one is really meant for analysts. I understand that it's a little bit hard to read, but if you were to receive a data cut with all the opioids prescribed in 2019, it would look something like this. And as you can see in the name Ridge field, there's a lot of information captured in that field. So we have machine learning algorithms and pattern matching algorithms that would parse out the data within the name Ridge field and turn it into an ATC code. And then, which is a calculated name field, which is standardized. And in addition, you can see that we have raw data on the strength, dose, frequency, and duration of the medication. And we haven't yet completed this work, but we need to complete the work to create standardized calculated fields, which we can do. It's fairly straightforward. It's just a matter of, what is the priorities. So yeah, if someone out there has money for us, we'd happily do this year. So here's another example of how the data are cleaned up after it's input into the EMR by the primary care provider and then following extraction. So currently we standardize over 50 different labs, and we are continuing to add to this list. And so as you can see from this table, the EMR text holds the raw data extracted from the EMR, and the clean text test results show how we transform the raw results into coded, standardized data that can be used in any analysis. And so here's one case study, and I call it QI opportunity number 1. It's really trying to understand data completeness, and this is something that can be done by any provider, any practice, because there is variation in the completeness within each field of the Simpson database. And while there is some variation depending on the EMR product, most of the variation arises when the provider inputs into the electronic medical record. And so some fields such as sex and birth year, they're very well populated. If people are billing for diabetes, this is another thing that's really well populated, and there's minimal missingness. And then there's other variables such as height and weight, or smoking status that can have a large amount of missing data. And it depends on where the data are input. Sometimes the EMR doesn't have a specific field for something like smoking status, so it ends up in the clinical notes, which we at this point are only starting to extract in some regions. And then sometimes it's just not entered into the field. And this is showing an example of individuals and practices interested in improving their EMR data. And we have seen this to be useful when there is an external reason to do this. So as an example, when community health centers are providing reports to the BC Ministry of Health, they needed to understand exactly what they were doing in terms of, for instance, group medical visits. And those are things that can be coded, and you can look at it by completeness by provider. So this is something, a QI opportunity. You could use the Simpson data for this, but I'm sure a lot of electronic medical records probably have this kind of functionality that's in it. The second example of QI is how Simpson is working to support QI over larger geographic areas. And in this case, this is a primary care network. It's the Kootenay Boundary Primary Care Network, and how they are working to create this culture of learning. So this is a slide from my colleague, Dr. Jen Ellis in Kootenay Boundary. And what she has said here is culture enables structures and structures enable culture. And here is the next slide, is showing you the Kootenay Boundary learning system. And these are different things that they do in order to create a learning system. And the boxes that are circled in blue are showing how Simpson is part of their learning system. So you can see that in order to create a big learning system, there's lots of different things that have to happen. And Simpson can be part of this. We have a robust toolbox in terms of a data presentation tool. We can provide reports on outcome metrics. We also do, as I've said, some regular and automated data collection. And then we're working in partnership with Kootenai boundary, the physicians and the practices there. And then also that division of family practice to share learnings and have partnerships with other research organizations. And if physicians or practices in that region wanted to do pilot studies with their data, we would be able to support them in doing that. And here is sort of just to give you a sort of a overall view of some of the structures that they're needing to put in place in order to have this happen. Then you can see there's a need for QI coordinators and coaches. They actually invest a lot of money on people time because they don't want to burden the providers who are very busy seeing patients. And then they have a framework that they use. They're running a patient experience survey. And then you can see there, Simpson is being used for EMR analytics. And as Gail prompted me, we do also have not only the EMR analytics, but we also collect data on the organizational structure of practices so that we would be able to put those data together. And as we move into the future, we're looking at instituting linked patient experience survey data with EMR data with the organization. So everything would be practice-based and would be available to practices to look at their data. So that is the second sort of example. And here's something, that could be scaled up at a provincial level. Here's something that could come out of the Simpson data once we've extracted and cleaned it. This is looking at a quality improvement indicator. They were very interested in, can you get at colorectal cancer screening in using the EMR data? And here we're showing you how we would get to that and what's needed to actually create these kind of indicators. So there's lots of, it's not only getting the LOINC codes, the lab codes, but it's also understanding who's eligible for the colorectal cancer screening indicator, and then also excluding particular patients because they would not be getting a colorectal cancer screening because of their conditions. So there's a lot of work that goes into really trying to understand what is the actual appropriate denominator, and then what is the appropriate numerator that you would need to create these kinds of indicators. And then the third example of QI is, so I've showed you an example sort of at a practice level, individual level. Then I've showed you something that happens sort of within a geographic region and how that could be scaled up to a provincial level. And that's assuming that obviously there's a lot of practices that are submitting data to Simpson to give you enough saturation so that you're going to get a reliable indicator. And then this is another QI opportunity, and this is something where we're partnering with Choosing Wisely Canada, and it's an example of QI work at the pan-Canadian level. So we're trying to reach primary care clinicians and practices to work on reducing unnecessary tests and treatments. And we started in this area of antibiotics. And we hope that this kind of static report is taking lessons learned from implementation scientists, such as Dr. Noah Ivers and his colleagues, who have already done so much work in this area. And in order to prepare for this seminar, I actually watched Dr. Ivers' KT Canada series that he did. I can't remember if it was last year, but it was really saying, these maybe we've reached stagnation in terms of audit and feedback reports. And we're hoping that this new sort of innovation of putting these kind of reports together would make us move past stagnation. So we worked with primary care clinicians to show them individual level feedback. And you can see there, they wanted to understand how are they in particular doing. And then it's compared to the province in which that Simpson node is. So I can just tell you, this is a provider. He has allowed me to share the data. You can't know who this is, but you can see there's a provider ID there in that square box in the right-hand corner. And you can see that, this person, they're getting a green light. They're doing well in terms of antibiotic prescribing, specifically for respiratory tract infections. And then this is Ontario. And then you can see across pan-Canadian citizens. So that's using all the data that is across the country. And so you can see on this specific page that this person is doing well. And then the second page of the report really provides choosing wisely guidelines. So we've heard from providers, don't just tell me how I'm doing. I want to understand what else I can do in order to improve. And so we provided choosing wisely guidelines on antibiotic prescribing here, and it gives useful information if and when prescribers are ready to act. So again, this is still a static report, but this is very interesting. Like, okay, someone's coming in for a common cold, antibiotics are never indicated, et cetera, et cetera. So this is sort of a quick way to do this. And then there's a third page of the report, and this really helps providers to give patients something that they're looking for. So the last page provides links to download viral prescriptions and language for prescribers to use with their patients because most patients are wanting to understand what their diagnosis is, the management of their symptoms, and the information on the expected clinical trajectory. And we also have Choosing Wisely has done this, where viral prescriptions have been developed and are available in 3 different electronic medical records. So this is Acuro, TELUS, the PSS system, and then Oscar. And they're also working with other vendors to have this viral prescription sort of add-on that providers would be able to use. So we're trying to multiple different ways in which to help providers with working with patients. So this is just a slide to show you the different kinds of tools that we have at Simpson to really kind of look at to provide an overview of the scope and quality of the data and kind of the things that we can do. So this is some of the intelligence that has already been created by Simpson. And there's been different researchers and scientists that have done this. So this is definitely a pan-Canadian effort. And this is being done with researchers, scientists, data managers, and clinicians across the country to provide these resources. So first of all, you see that there's a data presentation tool, which is front-facing for clinicians to use. And it is able to, at the practice level, for individual clinicians, re-identify their own patients so that they can use this tool for purposes of recall, et cetera. It does sit outside the electronic medical record because we don't want anything to touch the electronic medical record for legal reasons. So we leave the electronic medical record alone, but we have a data presentation tool which people can use for their own QI purposes. And then you can see there's a number of different kind of reports here. So there's a measures of vulnerability report, which is underway right now. It's being led by Dr. Simon Derouge. And then a team from Alberta led by Dr. Stephanie Garys completed a denominator report, which examined which tables within the Simpson database should be used for defining a patient contact group. So that's really, coming from it from an epidemiological lens, which is great. And then I'm going to show you some work that we've done on the representativeness of the data, because it seems like a lot of people are interested in the representativeness of the data. Okay, so first I'm going to show you some tips for improving the science of quality improvement in primary care. So these are kind of, again, tips that come from the field. So QI, not quality assurance, it really needs to be based on data literacy. So clinicians and practices, need to continue to talk about the data and what the data are showing, et cetera. And obviously they need support for that. It needs to be value added, the quality improvement. It can't be mandated. There needs to be sufficient resourcing. And obviously Simpson, we would definitely say that, you have to have data and that's reliable and valid. It's coming from a trusted source. And then you need to expect that there's going to be imperfection, because as with anything, it can get messy. So there needs to be sort of an openness to imperfection. You should try to focus on outcomes and understand what you're trying to achieve. If you can triangulate those data. So we always ask clinicians, does this number make sense to you? And then if it doesn't, find another way to measure it, or find ways and partner with researchers to really kind of dig down deep into the issue. And trust and relationships is paramount in the work that we do. And we have trusted relationships with many clinicians across the country in order to be able to do this work, because it's not without their acknowledgement in Simpson and what we're doing that we can do the work without them. And then the data must be able to go back to the clinicians who are submitting the data, and these data must be disaggregated to a level which is helpful both to the individual but also to the environment in which they're working. And then, to try to create a data learning system is really helpful in terms of those kinds of things. And then I'll just end on slide 22, and then I have questions that I'm gonna throw out for people. So this is just a slide showing you the representativeness of Simpson. And what we say here, and we've looked at it compared to the Canadian census, and overall you can see that it's not representative of the general population, but it's reasonably representative of the Canadian primary care population. And we know that 85% of people have a family physician or nurse practitioner and go to a primary care place, but there's 15% that don't. And obviously that varies depending on where you are in the country. Simpson definitely has patients that are older in it and more female compared to the general population, but that's also very typical of a primary care population. We do have good representativeness across urban and rural patients, and we're working on making it more representative across the country. As I was mentioning earlier, in terms of different networks being started up. And it's important to remember that it is the model that Simpson started with was supposed to be a Sentinel surveillance network, so that there would be these practices that would give early warning signals. So it's never meant to be population based. But there are ways in which we can move to having the data be more representative, and it really depends on what you're looking for in terms of representativeness. There have been over 200 peer-reviewed publications. So it does have good quality, and there are a lot of ways in which the data can be used. Both for QI, but also for research and public health surveillance. Okay, I'm gonna stop now, and people can ask questions or whatever they'd like.
Awesome. I'm gonna go off mute for a sec while people think of their questions. And I guess I wanted to maybe start by thanking you and just sort of reiterate that Simpson is this basic, like there is support from the National College, but basically it's a grassroots kind of effort by primary care clinicians to understand what's going on better in primary care in a more systematic way, and then hopefully use those data improve what's going on in a more systematic way. So it's really exciting to hear about that. And it really is the sort of foundation for a whole bunch of KT or potential KT initiatives. With that in mind, Sabrina, I wondered if you might tell us about of any kind of QI or KT initiative that's leveraged the Simpson data. Which one's your favorite?
I think it's definitely the one with choosing wisely, because they have some content that they've done. And this is a sort of an initiative that's just underway. And so we have individualized reports where we're doing some pilot work right now. But the hope is that we would be able to do this across all the contributing practices. So that would mean we would be providing reports to 1,400 clinicians working in different practices. And then to move to, okay, what would be intervention? So, one intervention is a report, but there's probably other ways we can try to decrease inappropriate antibiotic prescribing. And we're just working on a report right now to provide some baseline data. And there's a lot of inappropriate prescribing going on in the RTI, respiratory tract infection world, up to about 30% is what we're kind of finding. So it's kind of exciting to know that there is room for improvement, and that Simpson might be able to help.
Mm-hmm. Such an important space because inappropriate antibiotic prescribing does contribute to antimicrobial resistance. And we all see right now what it's like when we're overcome with pathogens that don't have a good treatment. Not a good situation. So that's, can totally relate to being excited about interventions in that space. Do others have questions? I have some others that I'll pose, but I'll just pause for a sec. I see that Jennifer has her hand up. Yeah.
Hi, Sabrina. Thanks so much for your presentation. It's always very interesting to hear about the representativeness. And one of the aspects I think I struggle with in the primary care space about implementation is the people who are engaged, and you'll change them, but they're probably plateauing. And the people who aren't engaged. And how do you find them and bring them in? And especially things which Noah will talk about, we'll be able to talk more about, but things like my practice report in Ontario, you have 90% of physicians in one model get it, and only about half of physicians in another model. And so things like Simpson, how are you reaching out beyond sort of that engaged group?
Yeah, that's a really good point, because we work on sort of a voluntary basis, right? So we only work with people who are going to volunteer. So there is like a whole group of people that are not engaged and don't really want to understand what they're doing with their practice. They just, they're not really kind of there. So that group is really hard to get to. But even in our even though people are submitting data to Simpson and being part of it, what we're finding is that there's still 50% of physicians who are or prescribers that are inappropriate prescribers. So even within an engaged group where they're like, okay, yeah, we agree with the premise of Simpson and what it can do, there's still a lot of variation in there. And I still think I think what we need to figure out in sort of the Simpson network nodes is how do we reach those people where for instance they have inappropriate antibiotic prescribing, because even if we reach them, we could be saving the healthcare system actually probably millions of dollars. So yeah, and I mean, I think the other thing, Jennifer, that we're working on is Indigenous data sovereignty and data governance. We have Dr. Barb Zellick and Brianne Wood from Northern Ontario Medical School. They have a node up there, and they've been working with Indigenous partners to create a Indigenous data sovereignty and data governance structures, so that we would be able to start to partner with other communities. So that's yeah, we need to work with people like you, though, really.
Yeah, I always laugh because I'm like, sometimes I feel like we're pushing inequities for patient groups, right? So if you're in a group where somebody's engaged, you get data, services, et cetera. And so I struggle a little with that. So it's great to hear. Thanks.
Really insightful question. Just in thinking that if we help those who are already keen to improve further, actually the sort of disparities between the haves and the have-nots can get larger. And so we want to think about that. Not that we shouldn't help those who are willing to improve, but we have to think about how to engage the others. Did others have questions?
I have a question. No, I'm just wondering, so, looking at that report, like, what's your thoughts now on sort of audit and feedback, and can it help? And what's needed to support those kind of, sort of static reports, if you will, in terms of audit and feedback?
We probably don't have enough time to answer, but I'll give some short tidbits. So we've published in this space specifically around antibiotics. We've completed one trial, and I can send you, it was led by my friend, Kevin Schwartz. The audit and feedback reports about antibiotic prescribing can absolutely make a difference in and of themselves if they're done at scale, because the difference they're going to make is small, but on a population scale, we've shown that can be cost reducing, absolutely, and be quite impactful. And antimicrobial resistance exists on a population scale, so that's actually quite sensible. I think one of the challenges is that nearly everybody overprescribes antibiotics, and so comparing to the average in your region may not be ideal, because you're actually indicating a substandard target.
Right.
But figuring out what the target should be is very difficult. So then I would say we actually have a couple ongoing trials right now in that exact space to figure out how to get the most out of antibiotic audit and feedback sort of forms, as you put it, static sort of things. So there's I can tell you more in perhaps 6 months when we have the results. I think, but just bottom line is, yeah, absolutely, it can work. It can shift things on a population scale. And we have still work to do to figure out how to optimize the format of the report to, maximize the response.
Yeah, the whole area of visualization and how you do that is it's a science as well.
Yeah, I think one of the things that we found, just to make a quick sort of suggestion for your forms, is that there's a lot of evidence now that shorter duration antibiotics is just as good as longer duration. And, then you're exposing your patients to less antibiotics, which is a good thing. So, immediately you can think about embedding, feedback about what proportion of, prescriptions were longer than 7 days. We got really strong response to that because most prescriptions can easily be less than that. So that's one very specific thought for you. But it raises a larger issue, which is, are you measuring something that people, that they care about? Can you convince them to care about it? in some way, like how do they prioritize that against all the other things they care about? One of the challenges of, primary care is that we care like about everything. So, so it's hard to, whatever you're measuring, to make sure that it's going to be salient and actionable, and so on. And that the perceived way that you're measuring it is sort of, valid and actionable.
Yeah, absolutely. And so we have a tool, it's called the data presentation tool, which has a number of different dashboards on it. And people can look at like the diabetes dashboard, the chronic kidney disease dashboard, dementia. So there's a bunch, and there's standard reports, you can do customized reports. There's all kinds of things you could do. And we're finding that it's a lot of overload. So there's a need to sort of organize people, either within practice, but probably within a geographic region, so that they then can say, okay, no, this is our priority. And then you kind of get everybody doing that one priority. So it's like a bigger QI initiative than just one person working on their own. And I think, if we take the examples of like running in a run group versus training on your own, I think that people probably kind of like the accountability of going to a workout, or if you're in a book club, you'll read the book. And again, as Jennifer has pointed out, this is for people who are engaged, but it at least helps people move the dial. They want to.
Yeah, I think we have lots of theoretical reason and empirical reason to, encourage some sort of social aspect to the feedback process, for sure.
Yeah.
Megan, we're coming to 10-2. Do you maybe we could solicit for further questions, and then I want to make sure that you have a chance to, direct people to the wrap up or whatever. Yeah.
For sure. Yeah. I see one just came in the chat. So we can take that one and then see if people have additional questions after that. And then
Sabrina, can you see that question there? It's a really good one. How does the Simpson reports overlap with maybe other reports that are happening? I think this is referring to one that happens in Alberta.
Yeah, it's a good question. I haven't looked recently at the HQA panel reports. So there probably is some overlap, but I think the HQCA probably has access to different data. So I think they have access to administrative kinds of data. So there would be some overlap, and then there'll be some things that they won't be able to provide. But it's a good question, and I'm looking forward to colleagues that are going to create more of a sort of a QI dashboard, because I think the data presentation tool, while it's a very powerful tool, it maybe is a little bit too clunky and serving multiple purposes, which then makes it harder to use. So yeah, that's what I would say about it.
Yeah, one of the things that does happen in Ontario is that a family physician, should they choose, can actually get data from a whole variety of sources. Sometimes those are in perfect agreement and sometimes not, and that can be quite annoying. So it's something to watch out for, I suppose. Okay, I think back to the Central KT Canada team.
Okay, so I'm going to do my wrap up, but please, anyone, if you have another question, please feel free to pop it in the chat or raise your hand. So thank you so much, Dr. Wong, for that really excellent presentation. We really appreciate you spending your time with us. And also, Dr. Ivers, thank you. It was really great to have someone with so much experience in a similar area moderating. Our next KT Canada seminar will be 4 weeks from today with Doctors Janet Jull and Jennifer Walker. And I'm going to put the evaluation link in the chat there, and I'll also send it out. And this will also be posted on our YouTube channel with Dr. Wong's permission. We'll discuss to make sure. But yeah, so thank you so much, everyone, and wishing everyone a great rest of their day and upcoming weekend.
Thanks very much, Megan, for having me and the KT
Thank you,
team.
everyone.
Thank
Great.
you. Bye-bye.
Bye.